Here we have a picture of the pancreas, the position being under the stomach, next to the bile duct, the gallbladder and the liver. The gland itself has a head and a tail, and when a tumour is found on the pancreas, it is likely to put pressure on the bile duct, thus indicating a degree of jaundice in the body. On the second slide you will see a tumour on the head of the pancreas adjacent to the veins and the arteries which surround the gland itself, hence the high degree of difficulty when it comes to invasive surgery. The alternative to invasive surgery is stereotactic radiosurgery that we'll come to later. Here again is an example of a cancer on the pancreas affecting the liver to the right hand side of the picture. Once again it is quite identifiable that the tumour, and this is going to be the subject of stereotactic radiosurgery in the future. The next slide shows a bar chart of the 5-year survival rates of various cancers. You will see that pancreatic cancer is 3% survival rate over the 5-year period and is the lowest by comparison to the other areas of cancers. It is that which has stimulated Operation Henry to do something about improving the survival rate. And we hope that these causes, as you can see, are going to decrease. The government has made wonderful steps in preventing smoking in enclosed spaces, which does help the National Health Service and the budgets accordingly. But we do see that the causes of pancreatic cancer can be varied, obesity being one of them, and of course diabetes is an area that is suspect with subsequent pancreatic cancer. The key facts regarding pancreatic cancer: nearly 8,000 new diagnoses in the UK in 2008, and it is the 9th commonest cancer in women and the 11th in men. 80% of cases occur above the age of 60, and it is the most commonest cause of cancer death. The survival rates have not improved for perhaps 30 to 40 years. When a tumour has been identified on the pancreas, a biopsy is normally required. The tumour may be resectable, which means there is invasive surgery requirement. There is a small risk of needle tract seeding and the high risk of a sampling error, of course. A biopsy is essential if the tumour is unresectable, and invasive surgery is not recommended. This will justify oncology therapy and stereotactic radiosurgery. Here is a very good example of a tumour on the pancreas, and by virtue of its prominence could be considered reasonable for the Whipple procedure and resection. However, the difficulty with the veins around the organ and the arteries around the organ does cause a problem. The outlook for pancreatic cancer is poor because many people go to their GPs too late, and the diagnosis is identified and it is too late for any major surgery, and because the cost of national screening is so high, there is no similar screening procedures as we've had in the past with colon cancer, breast screening and the like. The diagnosis of diabetes could indicate a pancreatic condition affecting the production of insulin. 50% of patients have recent diabetes or a decrease in glucose tolerance. Some possible tissue destruction, but this improves after resection. A diabetogenic factor does increase insulin resistance. One of the major symptoms of pancreatic cancer is depression, and this is where Operation Henry comes into its own, whereby our volunteer assessors, on meeting a patient, will identify the needs of that patient, and we will take steps to alleviate any depression and stress that might be caused by the disease. As you can see, it has a reputation that can cause people worry. Well, there are the challenges, as you can see, and we have got the hopes. And one of the hopes that are not shown on this slide is that we have now got a stereotactic radiosurgery in the southwest, and Plymouth Hospitals NHS Trust at Derriford hopes to be the leading cancer centre nationally to provide such stereotactic radiosurgery. Two machines are being considered at the present moment, the CyberKnife and the Novalis TX. As you can see, by March 2016, the Plymouth Hospitals NHS Trust has asked Operation Henry to provide facilitation to all patients who have been referred from the 7 hospitals with which we deal, so that patients can and their families can be accommodated at the Plymouth Hospital campus, and we're very proud to have been asked to provide that sort of facility for patients who are under a degree of stress as it is. You can see the new Novalis TX machine on the screen, and here is the comparisons between the CyberKnife and the Novalis, which the current commissioners at Derriford Hospitals NHS Trust are considering installing at the hospital, which will be up and running within the next year. You can see that the Novalis TX does actually have a stronger beam of the stereotactic radiosurgery. There's at least 1,000 MUs as against 800 with CyberKnife. The one advantage of CyberKnife is that on respiratory tumours, the beam does rise and fall with the movement of the tumour. The good news is that there is a stereotactic radiosurgery machine currently at Clatterbury Hospital in the centre of Aintree in Liverpool, and the Derriford Hospital in Plymouth is shortly to have the stereotactic radiosurgery unit, probably the Novalis TX, not quite sure, but it will be installed by 2012, being the hub of the servicing of all patients being referred to Derriford from the 7 hospitals with which we deal.